So can you tell us now, you mentioned entrectinib, can you tell us a little bit now about what is the difference between laro and entrectinib in the mechanism of action and the design of that drug?
Sure. Entrectinib is a much less specific inhibitor of Entrect. It also targets ALK-ROS. And the initial data sets suggested really significant activity in ROS patients. They did not have a whole lot of Entrect data to really to compare kind of apples to laro. I think in the last ESMO they did report a larger data set of close to 50-some patients with Entrect from the Stark studies. The overall response rates were somewhat lower than larotrectinib. I think in the 50% range to 50 to 60% range. The median progression-free survival, I think in that data set was approximately 10 months. Now, why is there such a difference? It's not clear right now, I think. It's whether it's just the patient population that they've chose. They definitely had much more CNS met population, given the fact that one of the kind of the selling features in entrectinib is that it could also cross the blood-brain barrier, and they were trying to enrich for CNS mets. So I think it's hard right now to compare entrectinib to larotrectinib. I get that question all the time, and which one's a better drug? I'm biased because I was I was one of the PIs for the larotrectinib trials. But right now, I think it's hard to compare the two.
So I'm just going to try to break down some of this to make sure I get it all, because I'm not always sure.
Yeah.
So what are exactly the targets for entrectinib? And does it target, and with that, can you tell us, does it target all the Entrect fusions?
Yes, it targets all the Entrect fusions, and every Entrect 1, 2, and 3. But it also targets ALK and ROS, right?
Okay.
And the more robust data set has been really in the ROS phenotype, and so they've gotten a lot more patients on that subset of patients, I think.
So can you, I know you said you weren't an investigator on it, but can you talk about the design of their trials? And you mentioned a little bit that they were enriching for CNS, but could you actually just tell us exactly what the trials were, how they were set up?
I don't know the answer to that question. It's similar to the basket study. The Stark trials were, I think, very similar to the basket trials that we did with Navigate.
So they allowed for multiple different tumor types, and
as long as they had Entrect or ROS.
So at this year's ASCO meeting, Bob Dobele from University of Colorado has actually done an analysis comparing outcome for entrectinib and crizotinib. Now, realize that entrectinib is also an Entrect inhibitor, but actually the bulk of data for entrectinib has been done in ROS1 and ALK. The nice thing about entrectinib is it hits all. It targets ALK, it targets ROS1, and it targets the three major variants of Entrects 1, 2, and 3. The drug that we typically use in ALK, alectinib, has no activity in ROS1 and essentially no activity in Entrect. So as time goes on, we're going to need to be more and more cognizant of the various differences between these tyrosine kinase inhibitors and where the bulk of activity exists. Dobele has compared entrectinib in 53 patients to crizotinib in 69 patients in the ROS1 world. So this is a bit off topic for Entrect, but still generally on topic in this whole realm of targeted therapy and therapies that specifically target gene rearrangements. And he used a unique endpoint. Instead of time to tumor progression or time to treatment failure, it was time to treatment discontinuation, which accounts not just for progression, but also for folks who may have had smoldering disease, smoldering progression, but were still having a clinical benefit. So it's sort of a real-world endpoint. It is not the typical endpoint that is used in most clinical trials, but actually has direct application to the world that we actually treat patients in. And his data are quite impressive. Entrectinib in this group had median time to treatment discontinuation of about 14.6 months compared to about 8.8 months for crizotinib, and survival appears to be better with this second or third generation ROS1 inhibitor. As of June, as of this year's ASCO, only larotrectinib is approved. We anticipate an approval for entrectinib probably sometime in the end of the second, more likely third quarter of 2019. It's hard to read the tea leaves on such approvals, but assuming it does get an approval, entrectinib will be the second Entrec inhibitor that's commercially available, and now one amongst several agents that'll also target ROS1 and ALK. So there are some minor differences in toxicity, I believe, between larotrectinib and entrectinib. Entrectinib does seem to cause some anemia. They both can cause fluid retention and weight gain, but entrectinib seems to be a bit more pronounced. And there is some neuropathy, peripheral paresthesias, peripheral sensory neuropathy associated with entrectinib. The total incidence about 13 or 14%, maybe about 4% or so that's grade 3. So clearly manageable, but a bit more pronounced. How these stack up against other agents or other upcoming agents remains to be seen, but I think for the most part, these patients can be readily managed with the tools that we have currently for side effects.